Welcome to our series of Healthcare Scene Google Plus Hangouts, where we sit down with top leaders in healthcare IT. My name is John Lynn, and I'm the founder of HealthcareScene.com, the leading network of 15 healthcare IT blogs, including EMR and HIPAA.com and EMR and EHR.com, along with the top healthcare IT career website as well. We have HealthcareITCentral.com for all your healthcare IT career needs. Thanks for joining us. And before we begin, I wanted to remind those watching live that you can submit any questions you have for us on the Google Plus event page, and we'll incorporate those questions into the Hangout if we have time. If not, we'll try to get back to you afterwards. So today we're excited to sit down with Lindy Benton, CEO of MEA-NEA. Lindy and the MEA-NEA team work with more than 40,000 dental and healthcare practices and providers, helping them better process claims, securely exchange information, and ensure the facilitation of timely responses to medical documentation requests from payers. Lindy has more than 20 years of healthcare leadership experience, so I'm pleased to have her here with me today. Welcome.
Thank you.
Good to have you here. Well, it's interesting. Lindy and I first met when you did a guest blog post with me, and in that blog post, you said something really interesting. You quoted a stat that said that there's more than 1 billion ambulatory care visits a year producing claims, and it needs 13% of those require an attachment to support them. So, with that in mind, and such a huge mass, what are we seeing with the electronic attachment exchange that's happening in healthcare today?
I think more and more electronic claim attachments are becoming a necessity for healthcare organizations, hospitals, durable medical equipment providers, and even dentists, because of the overwhelmingly large amounts of paperwork that's required by the payers to adjudicate the patient's insurance claims. We've all got those. For one visit, you might get, even as a patient at home, envelope after envelope after envelope telling you the status of the claim. So hospitals, we have a client, and down in Boca Raton, would used to send boxes of physical files to a payer for one single extended inpatient visit. So the medical record took boxes, the maximum UPS box to send. And we implemented Fast Attach for them, which is our tool that we use to do the secure exchange of documentation. And they have been able to replace those boxes with secure electronic files that are trackable. They know when they arrive. They know they've been picked up. And they went from a manual cycle, which was greater than 90% of the processes involved in addressing a denial. It was paper-based, fax, mail, and they're fully electronic. And they save well over $350,000 a year. And that's a lot for a 300 or 400 bed hospital.
Right.
That's just that one instance of paper. There's so much more.
Yeah. So, what are some other examples? Is it just to payers, or are there other places you're seeing this electronic attachment being used?
I think we're seeing it in several places. So we have so payers do audits of hospitals. So that's one very large area where medical records are today. You could put medical record techs, nurses, PAs, anybody who's going to go in a hospital and have to pull records and then read them and decide what they're going to fax or send. Today, with our technology, we have customers, like hospitals, who, instead of the expense of putting somebody on a plane, we know how much that would cost today, and that cost is sent back to the hospital. So it's the hospitals who pay that. Sure. They just send the medical records to our database, and those same people, at home with their bunny slippers on or whatever they're wearing, can actually go in, as we're talking today, they can go they can talk to each other, they can go in our repository, they can find what they need, and then just pull that over. So you don't have people on planes with rental cars and hotels, and it's secure. So that's, and by the way, we have seen instances where it's not secure, when someone is bringing medical records back on a suitcase on a plane that has to get checked, and now it's, now you're out of touch with it. So all of those cases, in my mind, that's a big one. The other that we do, we're the number one at, actually, is Medicare. So there is a audit process, and we've all heard about that. So during this Medicare audit, the audits are still sent by paper, so it's not perfect yet. CMS is working their way there, but all of those audit responses used to go back to the auditor, again, medical records being mailed or FedExed none of which is secure, and the hospital who is sending and the providers who are sending these medical records had no way of knowing if it arrived, if somebody picked it up. And these are timely, because if they don't get picked up in the time frame they have, which is 45 days, then that is assumed to be a fraud. They get the Medicare will, it's a liability. So we give them, got picked up, this is who picked it up, and this is who tracked it.
Interesting. So we basically are putting FedEx and UPS out of business, and the airlines, now that we're not sending as much. Yeah, I'm sure that.
Unfortunately, we still are sending. So but that is my dream. Yes, to put them out of business as a result of not doing that anymore.
Yeah, I'm sure they'll do fine. Amazon will keep them in business.
Yes.
So I
Good
mean,
point.
you cover kind of, two interesting points about why people are doing this. It sounds like cost is a big issue, and then also kind of the tracking piece. Are those the two biggest reasons of why people really want to go this direction, or are there other reasons?
I think there's obviously the security and privacy implications of the solution. So we talked a little bit about what that means, and I think today we're all starting to realize how insecure data is, and it's at a high risk, and with good reason. So with more and more people looking to perpetrate identity theft, the PHI is a hot commodity. So I think that's one reason. And if people fool themselves into thinking that paper files are more secure than electronic data, when in reality it's simply not the case. Paper files are more likely than electronic files to be a security breach. If you and I went to a hospital today and we walked by a nurse's desk, they're usually unattended, and medical records and paper are sitting on those desks. So we could pick one up and walk off with it easily. That has been done. There's many cases. So that's one. The other is, I think, that organizations will see a return on their investment because they get reduced claim denials. So one of the things we didn't talk about is the claim denial rates. So now there is a transaction proof that the attachment or the requested documentation to support a claim arrived at the payer, it was looked at in a timely manner, and the response was sent back, thus resulting in less denials. Again, I mentioned the $350,000 that the hospital in Boca saw, but they also reduced printing and shipping, so we didn't, that doesn't include that cost. Storing, so they had a huge medical records office where they had to store it. Well, we do the storing now, so that they don't have to have it duplicated.
Right.
And he said their staff is much more productive. They used to have, when they did this, they used to have the medical records put on one of those food carts, and they would go across the street to get the medical records out of medical records, and then bring them back across the street so they could do copies, and then send in the read them, send it in. So all of that's gone away, and it's so in addition to being
secure too.
HIPAA. Yeah, right.
a little food truck of medical records crossing the street.
I have to tell you that I was at a hospital once, pouring down rain. It was Florida, and someone was doing something similar to that by transferring and had their hands on top of this large food cart, so it's very common, full of medical records, and they went out into the street, hit the bricks. The medical records went flying across this rainy sidewalk, and they started just putting papers back into folders. So I guarantee you those papers didn't get in the right folders. And I have seen that more times than I can possibly tell you.
Yeah, it's a good point. I mean, and imagine in the rain, them getting soaked in the snow and the conditions. I mean, if it's in Vegas, I guess you're okay, but
yeah, maybe.
Yeah, twice a year where
And let me ask you: do you think the medical records director knew that those fell and that they were just putting papers back into other medical records? I'm saying no.
Yeah, I'm pretty sure there's not that big of a. Oh, I'm gonna go tell them about my screw up.
Exactly.
Someone, but not many.
Exactly.
Yeah. So that's really interesting. That you've made it more productive. I want to dive into the idea of that you have better claims or fewer claims denials. Is that because you're able to track your response, and know that they got it, or
exactly?
That's the key.
Exactly. I mean, what the process is today is the mail. It goes to usually a third-party mailroom, and once it leaves the site of the provider, they have no way of tracking unless they send it through, again, FedEx or UPS, where you have a tracking number. But even then, the person that signs on the other end is somebody in a mailroom. Right. So at that point, you have to unstaple You have to scan in, and then it has to get into the proper record and then go and, somehow or another meet the claim, because the claim is already there,
Yeah.
typically. So the supporting documentation has to somehow meet up. Because all that's automated, and when we send documentation, there's actually a number that will coincide with the claim that's waiting for approval.
Uh-huh.
And so somebody can so the person on the other end of the payer site can literally just go in through a work list and start approving based on the documentation, or even request more documentation because it's bidirectional. So they can say, please send me, additional, I got this, send this. And that doesn't happen today. Today, if that person reviewing at the payer site needs to go in and send and say, this is great, but I need one more piece of paper or one more scan or one more document, that drops down to a letter. They mail the letter. The hospital has to get the letter. It has to go to the right person. So now you're well within your time frame to get that denial overturned.
Hmm.
And you may not, how many times do you sometimes the letter never gets to you? Let's just put it that way. You throw it away or it just doesn't get there. So all of that is probably the whole process. It sounds painful just talking about it. We don't talk that way today. You and I would never, ever correspond about setting this up through letters. Because if we did, it would never get done. You could mail me a letter, I'll mail you one back accepting, then you mail me the. So we did that today in our daily lives. It would be really hard to function in this world today, but yet that's still how that process works for the majority in the payer provider world. They mail each other stuff.
Well, it's interesting you talk about the mailroom. I was just at an ACO and payer conference, and I sat down with some payers, and they were telling me about an experience just like what you described. They'd received this whole slew of mail, and they didn't know how to get it to the right person. Literally, they were like emailing around who should have this data, and you can imagine it's just sitting there for weeks not getting processed, therefore the claim's not being paid. And it seems like that's maybe, along with, if you're increasing the number of claims that are paid, fewer denials, but it seems like they get paid quicker. Is that true too? Because electronic gets there instantly, whereas mail could take 2 days. Phenomenal, really, but for a physical item, but still is slow, right?
Oh yeah, the Boca Hospital was taking 45 to sometimes 70 days to get paid on a single claim. They get paid within 2 to 7 days today. They have almost reduced their payment cycle. And that's really important to a health system, especially, again, no matter what size you are, getting paid fast is really important. So I think that's really important. And to me, I can't figure out why a payer, if you think about it, just wouldn't do it electronically or demand that from the providers, just send it to electronically. We're all in the same world, because when they go home at night, they probably all have iPhones and iPads and Droids and Androids and things, and they're texting each other. So they would never behave like that in their life today, but they behave like that at work. And the answer is, years ago, payers either invested in or have very large investments in mailrooms. So to shut that down, to go to an electronic process, it would save them a lot of money, but in today's world, it's not enough for them to pay attention to. It's just how things are done, and they're not interested in exchanging. There are some payers who are paying attention to that today, but for the most part, they're still doing it through the mailroom.
Well, it would save them money on the mailroom, but wouldn't it also? They, playing devil's advocate, as a payer, which I don't do often, but they kind of benefit from denying more claims and slower payments, because then they get the float on the money. So I imagine that's a disincentive to go electronic as well, right?
In their defense, I have had CIOs of payers, chief operating officers of payer organizations, who worked in the payer world for many, many years and in senior level positions. And I think everybody we've talked to would say, and I think we all believe that's true, to hold the money. None of them have ever at least admitted to it, but they really believe that that's not the case. They've never had a conversation inside payer walls about that. And it doesn't make sense that the money that they actually spend on the communication and the time going back and forth on a claim makes them any money. It's just, in my opinion, in our company's opinion, bad process.
It's interesting. Those same payers, these same payers that I talked to, they described a situation where they waited till the last day that they could pay them, and that they were doing that because they just wanted to keep their money, so that they could, pay them at the very last moment. And these payers said to me, "You're giving us far too much credit. Our processes aren't that good."
That's exactly right. Because we all think they're waiting to the last minute, and I'm telling you, I have never had a payer say that. It's always just a bad process, and it's sort of like waiting to the last day to get your homework done. They know when it's due, and they're scrambling to get it done because on their side they cannot deny a claim that they have in house just because they didn't get to it. So they do owe the provider an answer in a timely fashion, just as the provider owes them an answer.
So let's talk about. I mean, we've talked about the benefits, which I think everyone knows. Like, it's more efficient to do electronic, right?
Right.
So but I'm sure they're saying, well, how much is it going to cost me to do this electronic? So what are the costs associated with moving electronic? And we've talked about the benefits. What are the costs?
My gut reaction to that is to tell you that the answer is really what's the cost not to implement electronic claim solution. Mm-hmm. Because healthcare organizations are throwing money away every single day using that paper-based process. If you think of all the people in a hospital who has to touch the paper, go get it, touch it. Remember, if you're looking for something specific like lab reports, clinical information, supporting documentation, that is not a clerk. That is a clinically trained person who knows what in the medical record they're looking for. Mm-hmm. So it's really important to know these are very expensive people who are going through medical records, pulling the supporting documentation. You also have situations where some of the supporting documentation wasn't done within your own walls. So you've got to go find out where was that X-ray done, where was that report done. So there's all of that time taken. So by not having electronic, you've got to gather all that paper. And I just saw very recently a report that identified administrative complexity as a category of waste in the U.S. healthcare spending, and the cost of that, I believe, was somewhere between $107 and $389 billion annually. And we're all looking for money in healthcare, and wouldn't we rather that money go to patient care and wellness? I would.
Yeah, but you're making the case that the benefits offset any costs that they incur, which that's fine. I mean, many are probably what, or maybe this is an interesting question. Are they just waiting for their EHR vendor or their PM vendor to provide this service rather than doing another contract cycle with a different vendor? Or why aren't the EHR vendors doing this?
Traditionally, paper-based, anything that's on paper will sit outside the CIO's domain. So a CIO, typically in any hospital, manages all of the electronic systems in the hospital. So the surgical systems, the lab rads, any of the technology you see today, that is managed by a CIO. If there's paper outside of that, that does not typically fall into a CIO's span of control. So you're going to see paper all over. So a lot of it is because the EMR and the EHR and the PM vendors are working with those technology teams under the CIO to install technology. Mm-hmm. And this paper hasn't entered into that world yet. So you'll see a lot of that. Could they implement a solution? More than likely. The issue that they're going to have is that we are connected to hundreds and hundreds of payers. So maybe over 1,000 payers we have the ability to send documents to. Mm-hmm. So for an EHR and a PM vendor to go get that connection to those payers doesn't make a whole lot of sense. That's why we're somewhat unique in this market.
Interesting. So do you ever work with EHR vendors so they can just do a deep integration with you?
We do. Yeah, we have many vendors we work with. It's more, when we talk about integration, I would tell you we're probably more interface because it's not a deep integration. I can send to them through some links in our tools and send whatever documentation they need and get it to them the way they want it. So we do. We have several we work with.
Interesting.
Major ones.
So why aren't organizations just doing this? I mean, we all feel like, oh, this is, this just makes logical sense. Like you said, we don't do this in our any other part of our life. Is it just that maybe that divide that the paper billing world, claims world is different than the CIO, or is the CIO just too distracted by meaningful use that that claims person that says, please implement this electronic solution, and they say, let me deal with meaningful use, or like why aren't they doing this?
I think you just hit the nail on the head. There are a lot of distractions. Meaningful use is one of the many. There's all of the mandates, regulations that are coming at them a million miles a minute. They're trying to take the resources they have and put them on those I guess projects that will either make them more money, save them the most money, or keep them out of jail. So when you think about that, we certainly save them money. We certainly can make them money, and we can certainly keep them out of jail. But there are so many larger initiatives that the impact is so much greater. It's harder for them to just stop and make that process change overnight. A lot of them are thinking about it. We're having discussions, and they're talking about how we can start eliminating pieces of paper. So I think in a lot of our customer sites, we start with a single project that might be a smaller one in the scope of it, and then begin to creep up. So it's going to take years to get to where we'll never get to where all the paper's gone. I mean, I think the days we used to all talk about paperless medical systems, no one says it anymore because we know it's ridiculous. But sure. I think none of us lost our dream that there's a paperless medical system in our future. So yeah. It's not a large scale project, so a lot of them are willing to start small, and we kind of stay out of the way. But I will tell you, most of the IT departments that are working on those regulations, changes, and meaningful use really aren't even involved in the projects. It's really the revenue cycle management teams and people like that. It's not a technology play.
Huh. Yeah, maybe I've hung out with a lot of those people, and a lot of them aren't looking necessarily for tech solutions. It's kind of maybe a little bit the devil they know, right? They know the paper world, they know the goods and bads, and so they're not ready to learn another technology. Do you see some of that?
No, I think they'd be willing to learn. I think a lot of them don't even know what's out there in paper. Another great example is when we are able to take documentation that's sitting in paper. A lot of that's research document. So there's a couple of projects that we're talking about where research documentation is put into our database, so all researchers who are working on that project across health systems can view that research. Can you imagine how much research is lost while it sits on paper? I mean, for me, there are so many people who can be helped. There are so many diseases that we could probably escalate, treatment care plans and things that are sitting on paper today. That to me is probably the worst part of all forget the security, the cost, and all that. I think we strive, and our company looks to say, how can we make healthcare better? And I think just making sure that everybody has access to any data on you when you go into a situation as a patient. Don't you want them to know everything about you if you're unable to tell them before they treat you, right?
And are you working on that problem, really the kind of patient-focused side of things, where the patients can access these documents, and and really it's an HIE, I guess, exchange of the patient information. Right. Do you work on that as well?
We're working to include our documentation as part of the overall medical record wherever it exists on the patient, because it's not separate, right? I want to incorporate what I have into the payer network, so I mean, think about a day. I don't think today, when you go into an emergency room and you weren't unable to speak, that a physician thinks to reach out to your payer to see if they have information on you. But in reality, a payer would have a lot of information on you, including the last time you were seen, and maybe you were seen for something, maybe you saw a cardiologist. The payer knows that, and the payer can tell an emergency room doctor, he was seen 3 weeks ago, had an EKG, had some tests, might not know the results, they might or might not, but at least as a physician, I know where to go immediately, that you could have possibly had a heart attack. That is timely, critical information. It doesn't happen today. So until we can get these systems talking to each other to where, John Lynn is one person in the system, and that's what I hope. I hope one day in the future I see paper being eliminated from the provider workflow, because that's where it usually starts. And our goal here is to really get the providers to do it electronically, and then maybe the providers force the payers to change. Because I always think about, if you think about the drug companies, the Mercks and all the drug companies of the world, they stopped. They really are still selling to providers, but who do they really sell to? It's us. So that when you and I go to the doctors, I'm asking for a very specific drug that I think is going to fix my problem. Brilliant marketing, by the way. But if the providers can ask the payers to say, I want it electronically, then maybe we can force the change. And that's how it happens, right? We know today that it's social media that drives change, the biggest change in the world today.
Yeah, I just saw an announcement from Healthtap where they listed, they essentially aggregated from all these doctors a sort of rating system for how well drugs treat certain things. And at first I was like, I don't know how this is going to work. And then I pulled it up, and then I pulled up my 7 conditions I've had throughout my life. Acne.
Starting really early, yeah.
Yeah, exactly. Luckily I've dealt with that.
Apparently you solved that problem, yeah.
Yeah, so I looked at that, the common cold. There was a few things like that, that I looked at, knee pain, I think, something like that. I looked through some of these, and it literally listed the drugs, and I knew a bunch of them because I'd taken some of them throughout my life.
Or seen them on commercials.
Yeah, that too. I saw some of the commercial ones too, and I was like, I wonder how it's rated.
Right.
And these doctors rated how effective it was, right? I mean, think about that tool now in the hand of patients and patients going in. It's definitely a powerful thing for patients to go in there and do.
It's more than that, because I'll tell you, I became, I took care of my mother for many years before she passed on a couple of years ago, and she was a cardiac patient, and cardiac patients, as an example, see many, many different kinds of specialties. So they're cardiologists, the general, she's moving through the continuum, sure, including hospital stays. And I was her medical record. So I went with her on these visits. I was able to articulate, and I will tell you the drugs, that I knew all the medications she was on, and like you, I went and researched them, and I knew all the indications and the counterindications. So when they would prescribe her another one, I would immediately go online and say, wait a minute, that counterindicates another drug she's on, and it causes these kind of side effects. Are we sure? And and I'm not saying this against physicians, because there's no way that one physician's going to know everything about every drug and the counterindications. So it's all up to us, for our children and our families, to make absolutely sure we stay smart. Yeah. And so I spend a lot of time doing that. And I got a lot of, I would challenge her healthcare providers on, how to keep her care. And quite frankly, I think she lived another 12 years as a result of that interaction. Yeah. And I'll take every day of that 12 years, right? So.
Yeah, no, that's great. We actually just got a question, or a comment. Someone said to check out Revu, Revu. They have a solution to the med selection and affordability question. So, there's so many tools out there, that are going to be available to doctors that are just starting today. So I think that's great. I think I'd be remiss, though, if I don't ask you, we've talked about document exchange. Is that really the best? A lot of people would say, what about granular data elements and some of those things, which documents can sometimes do if they're attached to some metadata or things. Where is all this technology going, and is the document going to be the future, or what are we going to see in the future?
Don't get me wrong. The day where every single metadata that is done to you, again, for you, wellness and whatever, should be included in a single medical record electronically. So I would tell you, it's my opinion that a fully electronic medical record where all of your data sits in one place and you are able to access it by your phone, and when you go to your doctor, you can download it. All of that, to me, is utopia for me as a person and a patient. That being said, we have been trying to solve for paper for the last 20 years. We will be solving for paper in the future for the next 20 years. What will eventually stop that so we have an app which allows you literally to take a picture, and it doesn't store on the phone. You take a picture using our tool, securely send the picture, so I can take a picture of some incident, documents, whatever, and send them. That's the baby step toward getting all the information to where we can do analytics on it. We can share it. We can talk about it. And so I really think as a patient today, and as a person, I'm traveling across the globe as we all are. The day that we get on airplanes and go across seas is, I mean, we can all do it. I mean, Southwest is flying across, the ocean now, so it's affordable. We're doing it, but when you get over there, you absolutely have to have the medical record in your hand. And so any company that's allowing you to get, and by the way, if that medical record exists at your house where you're taking pictures of your medical record and you're traveling with that and you can show it to somebody, it's all a very important technology moving to the future. So do I think paper should be out of the system? Yes. Do I think it's going to be out of the system? It's going to be a very, very long time. There's still going to be documents like claims and all the kinds of things that we see on getting paid, and there's still going to be medical records being audited, and there's still going to be all kinds of, because you would assume to get rid of paper, everybody would have to be on the same system. And all those systems have to interact and talk. And again, we've been trying to do that now for 30 years.
Interesting.
Interoperability is a dream.
Yeah, and Nathan De Niro, he's watching live. He commented about an article on EMR and EHR.com that actually was written by Andy Oram, and he wrote about essentially there's some legislation that's being proposed that would essentially mandate interoperability and make it so that you had to be interoperable. Nathan says that patients aren't at the center. Do you have any comments on that type? I don't know if you've seen the legislation, but on the idea of government mandating interoperability, and should the patient be the center, or should there be something else at the center?
Well, I can answer that, and this is sort of a smart comment, but I can tell you how Obamacare worked out for everybody. That's the attempt at mandating. The train's left. We do need something where it's mandating some care for those who can't get care. We absolutely need that. Obamacare is a step toward the right direction. Not perfect. We need to fix and refine. But I think as part of that, you'll see some of the mandates coming through. And I'm aware of the interoperability and all that, but interoperability just means that my system needs to talk to your system. That doesn't mean that the patient is not going to have paper in their hands. Every x-ray you have, but go to an orthopedic office and you are in the waiting room sitting amongst files. They have so many images on the wall that to get those images in the to be interoperable is just, there's not enough hardware today in hospitals. It's not affordable.
Yeah. Well,
that's the problem.
And it may get there, and Nathan ends with the question, who should control access to that information? I think everyone knows the patient should control the access to it. And at the end of the day, the big vision is we need the right information in the right place at the right time. But that's a challenging problem considering our complex healthcare system. It
is. I would challenge you to even ask, parents, if you have a record of the shots your children have had, when they've had them, when they're due. That's a very simple thing, and most of us don't have that. And so that to me, until you start there, and then now you're asking for something complex as the boxes of medical records that we talked about, the Boca Hospital sent. Yep. How does that? Who has the hardware to bring all of that information into the history, into your past? And if you're a patient, you're not going to. What are you going to? It's certainly not going to fit on your device, right? So it's select what you're going to put there, but somebody has to store those medical records and have them accessible, and that is certainly what we do, and what we're planning to do in the future is at least have a place. We do have a product, Fast Vaults, that allows patients, the doctors, providers, to store. We don't do anything with it, secure it, store it, so you can easily store it there and then access it anywhere you are as a patient, as a doctor. But we don't today do anything with the metadata. I don't try to take fields off and do anything to it, because I think we do believe that there are security challenges around that if you're going to allow that to happen. So we're working through it, but I think that it's a holy grail.
Sure.
And by the way, I am the patient, regardless of what you're told, the patient owns your own medical record.
Yeah. And I don't think that will change, but sometimes policies make it seem otherwise.
Thank you. You're so right.
Yep. Well, we're up against the clock, but I've really appreciated the hangout and the insights and many of the stories you told. So thank you so much for coming.
Thank you for having us.
All right. Thanks, everyone, for joining live, and we'll have you again here on the Healthcare Scene Google Plus Hangouts. Have a great day.